Welcome back to the Vital Signpost. Today we're taking a deep dive into a topic that's absolutely crucial for nurses and, let's be honest, a little bit intimidating. Coagulation modifiers.
Oh, yeah, definitely essential, and for good reason.
Okay.
These medications can truly be lifesavers, but they also demand a really solid understanding of how they work and when to use them.
Exactly. So let's start with a little refresher on hemostasis, that intricate process of stopping bleeding that's constantly happening inside our patients.
Right, like a silent symphony, all those platelets and clotting factors working together in perfect harmony.
I like that, a silent symphony. And when that symphony gets out of tune, that's when we need to step in with those coagulation modifiers.
Yeah.
Some to prevent clots from forming in the first place.
And others to break down those clots that have already formed and could be causing serious problems.
Okay, let's break it down, starting with the medications that prevent clots, the anticoagulants. These are essential for preventing things like DVTs, PEs, and strokes, especially in patients who are at higher risk.
You've got it. And there are quite a few different types of anticoagulants out there, each targeting different parts of that coagulation cascade.
Right, we've got those older stalwarts like heparin and warfarin.
And then we have the newer kids on the block, the LMWHs and those exciting DOACs.
So much to unpack. Let's start with heparin, that old faithful medication that's been around for decades.
It's still a mainstay of therapy, especially in acute settings like in the hospital when you need to get someone anticoagulated quickly. Heparin binds to a protein called antithrombin III and ramps up its ability to inhibit key clotting factors, especially thrombin.
Like putting the brace on the clotting cascade.
Exactly. Now, switching gears to warfarin, it's an oral anticoagulant that's often used for long-term prevention of clots, but its mechanism is a little more roundabout. It interferes with the production of vitamin K-dependent clotting factors in the liver.
So it's not directly targeting those clotting factors, but rather disrupting their production upstream.
Exactly. You see, vitamin K is essential for making several of those key clotting factors. Warfarin essentially puts a wrench in that process, reducing the availability of those factors.
Okay, so with heparin, we monitor APTT, and with warfarin, we're watching INR, right? To make sure we're striking that delicate balance between preventing clots but not causing excessive bleeding.
Precisely. Now, those newer anticoagulants we mentioned, the LMWHs like enoxaparin, they're synthetically derived from heparin, but with a smaller molecular size.
And what's the advantage of that smaller size?
Well, for one, it gives them a more predictable anticoagulant response, meaning their effects are more consistent from person to person, and less frequent lab monitoring.
Always music to a busy nurse's ears. Okay, and then there are those DOACs that seem to be all the rage these days.
They really are a game changer in anticoagulation. They have a rapid onset of action, fewer drug interactions, and the big one, they don't require that routine coagulation monitoring.
So much more convenient for patients, especially those who might struggle with frequent lab visits.
Absolutely. Some of the DOACs directly inhibit thrombin, like dabigatran,
And others target factor ZAG, another key player in that clotting cascade.
like rivaroxaban, apixaban, and edoxaban. But remember, each DOAC has its own unique quirks, its own indications, and its own potential side effects.
So choosing the right anticoagulant, whether it's heparin, warfarin, an LMWH, or a DOAC, really depends on the individual patient, right? Their specific needs and clinical situation.
Absolutely. It's not one size fits all. It's a collaborative decision between the healthcare provider, the nurse, and most importantly, the patient.
Okay, we've covered medications that prevent clots. Now let's talk about those that target the first responders in that clotting cascade.
Yeah.
The platelets, those are the antiplatelet drugs, right?
You got it. They work by preventing those platelets from getting too sticky and forming those unwanted clots, especially in patients at risk for arterial thrombosis.
Right, those folks with things like coronary artery disease or peripheral artery disease.
Mhm.
And the most well-known antiplatelet, the one everyone's familiar with, is good old aspirin,
Yep, it works by inhibiting the COX enzyme in platelets.
which prevents the formation of thromboxane A2, a real troublemaker when it comes to platelet aggregation.
And helps keep those blood vessels nice and open. Now, another class of antiplatelet drugs that's widely used is the ADP receptor inhibitors.
Like clopidogrel, prasugrel, and ticagrelor.
Exactly. They block ADP from binding to its receptors on platelets, preventing them from getting that signal to clump together and form a clot.
So we've got aspirin blocking thromboxane A2, and these ADP receptor inhibitors blocking the ADP signal, both working to keep those platelets in check.
And they're often used in patients who've already had a heart attack or stroke to prevent another one, or in patients who've had procedures like stent placement.
Makes sense. Now, what happens when a clot has already formed and it's causing a major problem like a heart attack or stroke? We need those clot-busting medications, the thrombolytics.
Time to call in the big guns. Thrombolytics convert plasminogen into plasmin.
And plasmin is.
It's a powerful enzyme that essentially dissolves fibrin, that main component of blood clots. Think of it as a molecular scissor, cutting through that fibrin mesh and restoring blood flow.
So in those emergency situations where minutes matter, thrombolytics can be lifesavers.
Absolutely, but they come with risks too, mainly bleeding complications. So they're reserved for very specific situations and carefully selected patients.
Okay, so we've covered medications that prevent clots and those that break them down. But what about the opposite medications that actually promote clotting,
Yes, the antifibrinolytics or hemostatic agents. They work by preventing the breakdown of fibrin, essentially stabilizing that clot.
like adding some extra reinforcement to that clot structure? When would we use these?
Often during surgery, especially procedures involving tissues that tend to bleed a lot like the heart or liver, or in patients with bleeding disorders.
Wow, it's really fascinating how many different ways we can manipulate that coagulation process. And nurses are right there on the front lines making sure these medications are used safely and effectively.
Absolutely. We need to be experts in assessing our patients, administering these medications, monitoring for any complications, and educating our patients so they can be active participants in their care.
Well, we've covered a lot of ground in this first part of our deep dives into coagulation modifiers.
We've explored the mechanisms of action, the different types of medications, and even touched on some of the clinical scenarios where we'd use them.
In part two, we'll delve deeper into those crucial nursing considerations for each category of these medications, so make sure you tune in for that.
We'll be back with more on the Vital Signpost.
Welcome back to the Vital Signpost. In part one, we took a broad look at those fascinating medications called coagulation modifiers.
We talked about how they work, the different types, and when we might use them.
Now let's shift gears a bit and really focus on those crucial nursing considerations for each category of these medications. Those things we need to think about as nurses to ensure our patients are safe and getting the best possible care.
Absolutely. That's where the rubber meets the road. Let's start with the anticoagulants, those medications that prevent clots from forming in the first place.
Okay, so we've got a patient who's been prescribed an anticoagulant. Maybe it's heparin, maybe it's warfarin, maybe it's one of those newer DOACs. What are some of the key things we need to consider as nurses before we even start administering the medication?
Well, first and foremost, a comprehensive assessment is essential. We need to gather a thorough health history, allergies, current medications, past medical history, any history of bleeding problems.
And I imagine lifestyle factors come into play as well, things like alcohol consumption and smoking.
Definitely. Those can influence both the effectiveness and safety of anticoagulants. And speaking of safety, medication reconciliation is absolutely paramount.
Well, I bet there are tons of potential drug interactions with anticoagulants.
You're not kidding. So many medications can interact with anticoagulants, even some over-the-counter drugs and herbal supplements.
So it's really important to dig deep and get a complete picture of what the patient is taking.
Exactly. We need to be like detectives, uncovering any potential culprits that could cause problems.
Okay, so we've got the health history, the medication reconciliation. What about the physical assessment? Are there any specific things we should be looking for in patients receiving anticoagulants?
We're always on the lookout for any signs of bleeding, of course. Things like bruising, petechiae, bleeding gums, that sort of thing. We also want to assess vital signs carefully, especially blood pressure and heart rate.
Any changes in those could be a red flag, right?
Uh-huh.
Potentially indicating bleeding or other complications.
Exactly. And we're also assessing for signs of DVT, swelling, redness, or pain in the extremity.
Okay, so it sounds like a head-to-toe assessment is a must. Thorough observation and documentation are key here. And then there's laboratory monitoring, right?
Oh, absolutely. Can't forget about that. Laboratory monitoring is a cornerstone of anticoagulant therapy. For heparin, we're monitoring the APTT.
And for warfarin, it's the INR.
Right, and we want those values to be within a certain therapeutic range to ensure the medication is doing its job without causing too much bleeding.
I always found those lab values a bit tricky to keep straight.
Me too. A little trick I use is to remember that both heparin and APTT start with the letter H.
And warfarin and INR both have the letter R. That's helpful. Okay, so we've assessed our patient. We're monitoring those lab values. Now it's time to actually administer the anticoagulant.
Right, and the route of administration really depends on which medication we're using.
Heparin, for example, can be given intravenously or subcutaneously.
Exactly, and if we're giving it IV, we'll use an infusion pump to ensure a nice, steady rate. And for subcutaneous heparin, we're rotating those injection sites
Why is it so important to rotate those sites?
to prevent tissue damage and avoid injecting into areas that are already bruised or tender, and no injecting near the belly button.
Why not the belly button?
Well, it's just not a good spot for absorption and can increase the risk of complications.
Makes sense. Now, what about those LMWHs, like enoxaparin? How are they typically administered?
Usually subcutaneously, right in the abdomen. And again, we're rotating injection sites to prevent those nasty bruises. And most of those pre-filled syringes come with that nifty needle shielding mechanism.
Oh yeah, to help prevent those accidental needle sticks.
Safety first. Now, those DOACs, they don't require that routine monitoring, which is great, but we still need to be super vigilant in assessing for bleeding or any other weird side effects.
Right, they might not need those blood tests, but it doesn't mean they're completely risk-free.
Yeah.
And what about patient education for folks on anticoagulants?
Oh, patient education is huge, GE. We want to empower our patients to be active participants in their care, right?
Absolutely. What are some key things we should emphasize when we're teaching patients about their anticoagulant therapy?
Well, we definitely teach them about the signs and symptoms of bleeding, easy bruising, bleeding gums, blood in their urine or stool. Anything unusual, they need to report it right away.
And I imagine lifestyle modifications are a big part of the conversation as well.
You bet. We advise patients to avoid activities that increase their risk of bleeding, like contact sports or using sharp objects. Switch to an electric razor, use a soft bristled toothbrush.
Common sense stuff, but so important to reinforce. And diet plays a role too, especially for folks on warfarin.
Right, warfarin and vitamin K have this intricate dance they do. So we talk to patients about maintaining a consistent intake of vitamin K.
Not eliminating it completely, but avoiding those drastic swings.
Exactly. And of course, we counsel them on limiting alcohol intake, as that can really mess with warfarin's effects.
Okay, we've covered a lot of ground with anticoagulants. Now let's move on to those medications that target the platelets, the antiplatelet drugs.
Right. Those are crucial for preventing clots in our patients at risk for arterial thrombosis.
Like those with coronary artery disease or peripheral artery disease.
Yep. Before we even think about giving an antiplatelet drug, we need to do a thorough assessment, just like with the anticoagulants.
Health history, medications, any bleeding tendencies.
Right, and we also need to consider any conditions that might make antiplatelet drugs a bad idea. Things like active bleeding, recent surgery, or a history of intracranial hemorrhage.
Okay, so we've got our assessment done. Now we need to choose the right antiplatelet medication. There are quite a few options out there.
The choice really depends on the individual patient, their risk factors, the clinical situation. What are we trying to prevent?
Aspirin, for example, is often used for primary prevention in folks with moderate cardiovascular risk.
Right, whereas those more potent antiplatelet agents like clopidogrel, prasugrel, or ticagrelor, those are often preferred for patients who've had an acute coronary syndrome or who've undergone PCI.
Makes sense. In aspirin, everyone's familiar with that one. It's typically taken orally. Any special instructions we need to give patients about how to take it?
Taking it with food is a good idea to minimize stomach upset. And there are those enteric-coated formulations that can help with that too.
But don't crush or chew those enteric-coated tablets.
Definitely not. That defeats the whole purpose of that special coating.
Okay, and what about those ADP receptor inhibitors like clopidogrel? Anything special about administering those?
Clopidogrel is usually taken once a day, and it doesn't need to be taken with food. But monitoring for bleeding is still crucial, and we need to be mindful of those potential drug interactions.
Right. Some medications can interfere with clopidogrel's metabolism and make it less effective.
Exactly. It's always a good reminder to stay up to date on those drug interactions, especially with these newer antiplatelet agents. And speaking of newer agents, there are those potent intravenous antiplatelet drugs, the GPIBA inhibitors.
Those are the heavy hitters, right?
Yeah,
Used in those high-stakes situations like acute coronary syndromes or during PCI.
exactly. These are serious medications administered intravenously, and they require very close monitoring.
For bleeding, of course. What are some specific things we're looking for?
Any signs of bleeding, big or small, oozing from puncture sites, nosebleeds, blood in their urine or stool, bruising, and we're monitoring those vital signs like hawks.
Any change in blood pressure or heart rate could mean trouble.
Absolutely. And we're also keeping a close eye on their platelet count, making sure the medication isn't causing thrombocytopenia.
So many things to juggle. And in those high-pressure situations, it's easy to forget about patient education.
You're right, but even in those acute settings, patient education is still so important.
What are some key things we want to make sure those patients understand about their antiplatelet therapy?
We want them to understand why they're getting the medication, the potential benefits and risks, and those all-important signs of bleeding to report.
Right, empowering them to be our partners in their care. We've covered anticoagulants, we've covered antiplatelet drugs. Let's move on to those powerful clot-busting medications, the thrombolytics.
Those are reserved for those real emergency situations when we need to dissolve a clot fast.
Like in a heart attack or ischemic stroke.
Exactly, those situations where time is muscle. But they're not without risks. Bleeding is a major concern.
So before we even think about giving a thrombolytic, we need to make sure the patient meets those strict inclusion criteria and that they don't have any contraindications.
Absolutely, it's a careful risk-benefit analysis.
What are some of those key inclusion criteria?
Well, first and foremost, a confirmed diagnosis of a condition that would actually benefit from thrombolysis.
Like an MI, stroke, or massive PE.
Right, and the patient needs to present within a specific time window from when those symptoms started.
Because the sooner we can administer the thrombolytic, the better the chances of salvaging that tissue.
Exactly. Time is of the essence. Now, on the flip side, we have those contraindications, those situations where we absolutely would not give a thrombolytic.
What are some of those red flags?
Any condition that significantly increases the risk of bleeding. Things like active internal bleeding, recent surgery or trauma, a history of intracranial hemorrhage, uncontrolled hypertension.
So many potential pitfalls. It's a lot to consider.
It really is. We need to weigh those risks and benefits very carefully. Now, if we do decide to administer a thrombolytic, most of them are given intravenously.
Either as a bolus, followed by an infusion, or just a continuous infusion.
Right, and we'll use an infusion pump to ensure precise delivery, and of course we're monitoring the patient super closely throughout that infusion.
For any signs of bleeding.
Right, and we're talking any and all signs of bleeding, from those minor oozing to a major hemorrhage, and those vital signs are our best friend.
Blood pressure and heart rate, those are the canaries in the coal mine. Any changes could mean trouble brewing. What about lab tests? Anything specific we're monitoring during thrombolytic therapy?
We're keeping an eye on things like hemoglobin, hematocrit, platelet count, fibrinogen levels, and coagulation studies.
So many labs. It's like a whole panel to track those coagulation changes.
It really is. We need all those data points to guide our care. And even though this is an emergency situation, patient education still matters.
Right. Even in the chaos, we still need to take those few minutes to explain things to the patient.
Absolutely. We want them to understand what's happening, why they're getting this medication, the potential risks and benefits, and that all-important message: report any signs of bleeding, no matter how small.
Okay, we've covered anticoagulants, antiplatelet drugs, and thrombolytics. Now let's wrap up this part by talking about those medications that actually promote clotting, the antifibrinolytics, also known as hemostatic agents.
Right, these are the medications that help to stabilize the clot and prevent it from breaking down too soon.
Like putting a little extra glue in there to reinforce that clot structure.
Yeah.
When are these medications typically used?
Often during surgery, especially those procedures that involve a lot of bleeding, like heart surgery or liver surgery.
Or in patients with certain bleeding disorders.
Exactly. And the way we administer them depends on the specific medication and the clinical situation.
Some are given intravenously, some are oral, some are even topical.
Right. And just like with any medication, we need to be mindful of the dosage and administration guidelines. And of course, we're always monitoring for any signs of adverse effects, allergic reactions, thromboembolic events, that sort of thing.
It's a delicate balance, isn't it? Trying to control bleeding, but also making sure we don't cause excessive clotting.
It really is, and patient education is key here too.
What are some of the essential points we want to emphasize when we're teaching patients about antifibrinolytic therapy?
We want them to understand the purpose of the medication, why they're getting it, the potential benefits and risks, and that they need to report any signs of bleeding or clotting problems right away. Oh, and we also remind them to let all their healthcare providers know that they're taking an antifibrinolytic.
Their dentist, their pharmacist, everyone.
Everyone. We want to make sure everyone's on the same page.
Okay, we've covered a lot of ground in this part, exploring the nursing considerations for each category of coagulation modifiers.
From assessment and administration to monitoring and patient education, it's a lot to keep track of.
But it's all part of providing safe and effective care for our patients who are on these powerful medications. Now, get ready to test your knowledge. In Part 3, we'll tackle some challenging review questions that will really make you think. Welcome back to the Vital Signpost. In the first two parts of our deep dive, we really explored the ins and outs of coagulation modifiers, from how they work to all those essential nursing considerations.
It's a lot to take in, that's for sure.
It is, but that's why we're here, right? To break it all down and make it a little less intimidating. And now it's time to put our knowledge to the test. Are you ready for some review questions?
Bring it on.
Okay, here's the first one. And this is a scenario you might encounter in the emergency department. The nurse is monitoring a patient receiving antithrombolytic therapy for a possible myocardial infarction. Which adverse effect would be of the greatest concern at this time?
Oh, this is a good one. It really highlights the importance of vigilance when we're administering those clot-busting medications. I'd say the most concerning adverse effect in the scenario would be an irregular heart rhythm.
Interesting. Why would an irregular heart rhythm be more concerning than, say, bleeding, which we know is a major risk with thrombolytics?
Well, bleeding is definitely a concern, but an irregular heart rhythm could signal a life-threatening arrhythmia. You see, when those thrombolytics break up that clot and restore blood flow to the heart, it can sometimes trigger those arrhythmias.
So it's like a rebound effect.
Kind of, yeah. And an irregular heart rhythm could also be a sign of bleeding within the heart itself, which would be a really bad situation.
That makes sense. So we're restoring blood flow, but we also need to be super alert for those potential cardiac complications. Okay, next question. A patient is learning about warfarin therapy and asks the nurse about what medications she can take for headaches. Which type of medication should the nurse tell her to avoid?
This is a classic question that really gets at the importance of medication reconciliation and patient education when it comes to warfarin. We know warfarin has a lot of drug interactions, and some combinations can really increase the risk of bleeding. So in this case, the nurse would need to tell the patient to avoid any medications that also affect clotting.
Okay, so what are some specific examples of medications she should steer clear of?
Definitely aspirin and those non-steroidal anti-inflammatory drugs, those NSAIDs.
Like ibuprofen or naproxen?
Exactly. And some herbal supplements can also be problematic, things like ginkgo biloba. It's always best to err on the side of caution and check with a healthcare provider before taking anything new when you're on warfarin.
Great advice.
Okay.
Okay, moving on. The nurse is teaching a patient about how to give themselves enoxaparin injections. Which statement should the nurse include in this teaching session?
Oh, this one is all about proper administration technique. With enoxaparin, those subcutaneous injections, we want to make sure the patient knows to inject it into the folds of their abdomen at least 2 inches away from their belly button.
Why is that specific location so important?
Well, we want to ensure the medication gets absorbed properly and minimize bruising. Injecting into the folds of the abdomen, away from the belly button, helps us avoid hitting muscle or those major blood vessels.
It makes sense. Okay, here's another one. A patient is receiving dabigatran, 150 milligrams twice a day for atrial fibrillation. Which condition, if present, would be a concern if the patient were to receive this dose?
This question really emphasizes the importance of individualizing care and considering those patient-specific factors. In this case, the condition that would be a concern is renal impairment.
Can you explain why renal impairment would be a problem for a patient on dabigatran?
Sure. Dabigatran is mainly excreted by the kidneys. If the kidneys aren't working as well as they should, the medication can build up in the body, and that increases the risk of bleeding.
So we need to adjust the dose or maybe even choose a different medication altogether.
Exactly. It's all about finding that sweet spot where the medication is effective but also safe for that particular patient.
Okay, next question. A patient accidentally received a double dose of intravenous heparin after surgery and is now bleeding through their incision site. The surgeon is assessing the situation, and the nurse needs to be prepared to act quickly. What action should the nurse take?
This is a critical situation that demands swift action. A double dose of heparin can lead to significant bleeding, and we need to reverse its effects fast. The nurse should be ready to administer intravenous protamine sulfate.
Why protamine sulfate? What does it do?
Protamine sulfate is the antidote for heparin overdose. It essentially binds to heparin and neutralizes those anticoagulant effects. You can think of it like a magnet, attracting and binding to the heparin, taking it out of commission.
Fascinating. It's amazing how one medication can counteract another like that. Okay, last question. A patient is starting warfarin therapy for atrial fibrillation. Which principles of warfarin therapy should the nurse follow?
This question really highlights the importance of those key principles that guide safe and effective warfarin therapy. The nurse should always administer that oral dose at the same time each day. Be super vigilant about assessing for any bruising or unusual bleeding, and of course, monitor those INR results.
Okay, let's break those down. Why is consistent dosing so crucial with warfarin?
Consistency helps to keep a steady level of the medication in the bloodstream, which is essential for it to work properly and prevent those clots. If the warfarin levels are fluctuating, it can increase the risk of both clotting and bleeding. We don't want either of those.
And why are we so concerned about bruising and bleeding?
Well, warfarin does increase the risk of bleeding, so we need to be on the lookout for any early signs of trouble. Bruising, unusual bleeding, those are red flags that we need to address promptly to prevent more serious complications.
And why is that INR monitoring so important?
INR monitoring helps us fine-tune the warfarin dose and keep it within that narrow therapeutic range. Too low, and the patient is at risk for clots. Too high, and the risk of bleeding skyrockets. It's a delicate balancing act.
Wow, we've covered a lot of ground today, delving into those challenging review questions that really make you think critically about coagulation modifiers.
And it just goes to show how important it is for nurses to have a deep understanding of these medications. We're the ones on the front lines making sure they're used safely and effectively.
Absolutely. We need to be those medication experts, advocating for our patients and ensuring they get the best possible care. Well, that wraps up our deep dive into coagulation modifiers. We hope you found it informative and, dare we say, even a little bit fun.
A little bit fun and a lot empowering.
Until next time, remember, knowledge is the vital sign that guides us toward exceptional nursing care.
Thank you for joining us on the Vital Signpost.